focus of the medicine is to prevent the breakdown of that acetylcholine once it's released. So it breaks down in the cleft, and if we put mestinon, or if we put neostigmine, or if we put edrophonium into the system, it blocks that breakdown and keeps a higher amount of acetylcholine available there to continue to stimulate the muscle membrane over and over again. And that's where the benefit comes from. Edrophonium, or Tensilon, was kind of the go-to test, and it's been a little sketchy trying to get a hold of edrophonium on and off in the last handful of years. I know the foundation's fought hard for it. We don't use the test nearly as much as we did in the days before the acetylcholine receptor antibody was available. That was just coming into vogue 20 years ago when I went into practice running the antibody test. And so we did a lot more Tensilon tests. And the Tensilon test has always been probably one of the tests that attracted me into wanting to do neuromuscular diseases, my fellowship, instead of anything else. Have any of you guys had the Tensilon test done? It's kind of fun, especially as a student or a medical student, because you can go in and any of you can imagine what your worst day with your myasthenia was, I'm sure. And if you think about that, you know, we go into the emergency room, we put an IV into the patient, and we give them a shot of this stuff, and it makes it all go away. And it works really fast, and it lasts for about 3 to 5 minutes, and then all the symptoms come back. So it's really a very dramatic way of proving that that's the answer, and it's almost universally the answer when it is. The drug does have the potential of causing heart block and causing people to go into cardiac arrest. I've never seen it. I've probably done several hundred Tensilon tests at least over the years anyway. I mean, we're always watching for that. We used to do them in the office until I got too nervous to do them over there, and then we started doing them over here in the emergency room. But you know, we did them in the office with regularity for years. And again, it's just a very interesting thing. So that's why you don't hear the name edrophonium too much. It's also a nice if people go into crisis and end up in the hospital here, and I know at least a couple of people in the room have had that experience, I like to have it available because, again, it can kind of help me in the ICU or other places to tell whether we're over the top, as I said earlier, with the amount of mestinon that we're taking, because you know, give you something, especially if you're on the ventilator or something like that, give you a little bit of this drug and have it show me what an extra amount of mestinon would do over the next little while, and have it go in and come out in a matter of minutes is really useful, because if the patient gets profoundly weaker, you know, you're giving too much mestinon, you probably want to back off. If they clearly get stronger, you know, you can increase that with some confidence to try and improve those situations. And I don't always see that done. Again, I did a fellowship in neuromuscular, so I got a little more background than the other people in town. But it is a really good quality test, you know, in terms of working with that too. So I do like to have it around. So then you move into the immunosuppression types of drugs before we talk about, you know, other treatments as well. And probably the universal drug used most frequently for immunosuppression is prednisone. And prednisone is a steroid. You know, there's all kinds of steroids. There's testosterone's a steroid, estrogen's a steroid. Those are sex hormone steroids. So most of the time when you hear about steroids, you think about Roger Clemens and these types of people, right? And those are not the type of steroid we're talking about. These are called glucocorticoids, is kind of the official medical name for them. Gluco is in glucose, and one of the main, there's a number of side effects with these drugs, which is one of the reasons I don't love to use them, but we will use them. And one of the principal things with the glucose component of it is it can stimulate or exacerbate diabetes, and so you have to watch patients' blood sugars very carefully, even if they don't. Even if they don't have a history of diabetes, you can push them into diabetes. If they do have diabetes, you can make it a whole lot worse. It's an immune suppressant, so infection is potentially an issue for some patients with this. Any of the immune suppressions, you hear it on television now with a number of the, I'm being filmed, I didn't see that on the camera, I didn't see on television you see with some of the rheumatologic drugs now, they're saying if you have a history of tuberculosis, you can't use this drug. So you know, we're always concerned because TB is still in the population. It killed my uncle years ago, not that many, 15 or 20. And the notion that you know, it's out there in the population still, and it lays kind of dormant below clinical visage, is part of why we frequently have to go back and look for that perpetually in people and try and be sure that we're not going to knock them off, you know, with the medicines anyway, too. Prednisone doses, usually when we start people on it, I usually put people on only when they're really doing lousy, you know, because it can cause long-term use, and that's usually what you're talking about. It is associated with cataracts, diabetes, weight gain, osteoporosis, increased fractures, hypertension, fluid retention, just off the top of my head, okay? So the notion of being on large doses of that is pretty challenging, you know, for most people in the long run. And again, you know, the typical dosing that we put people on, and I tend to underestimate this a little bit when I put people on, is they want us to put people on 1 or 2 milligrams per kilogram, which for a guy my size who's about 100 and maybe 100, 120 kilograms, you know, you're talking about giving me almost 250 milligrams, and that's a huge dose, you know, of prednisone to give to somebody. So I'm much more comfortable 60, 80 milligrams a day, maybe a little bit more than that, and then, you know, you usually see some gains almost right away, but those will build over a period of some weeks. And then when we see those build and plateau is when we want to start pulling back. Now the other challenge with glucocorticoids is that they can cause wasting of your quadriceps muscle, which is this muscle right here, and it can cause your knees to get weak, and you can get what's called a steroid myopathy with high doses for a long time, completely independent of the myasthenia gravis, so it can cause shoulder girdle and hip girdle weakness to the point of having difficulty standing up from chairs, climbing stairs, working above your head, which is another one of the reasons that we don't tend to use that drug nearly as aggressively as pushing the mastodon up front anyway, typically. The rationale after a patient's been kind of given, it's not quite a burst, because, you know, we use burst steroids 3 or 4 days of it in MS a lot of the time. It's more of a hammer, I guess, if you will, where we give it maybe for a month or 6 weeks and then start to slowly back down over months to a lower dose. Typically something under 20 milligrams, we start seeing far fewer of the side effects. And ideally, we'd like to get people down around 5 milligrams or so, if we can, in terms of working with that. I've tried to wean people off in the past. It is a little dicey. It was interesting reading the Foundation's information today. They said you really should just plan on leaving people on 5 or 6 milligrams once you've committed to it, unless you put them on one of the other agents. And so that's kind of the general overview of the prednisone anyway, too. It's become much more popular of late to move people onto steroid-sparing agents, is what they're called. And this is Imuran and cyclosporin and Cellcept or mycophenolate. So those 3 drugs all have been used in cancer and in transplant work when they were initially released. Imuran's the oldest of the group. Always learning something. Somebody sent me a patient back the other day with a new blood test to look at before we put people on Imuran to see if it's going to knock off their blood counts. Problems with blood count, liver function are common with Imuran. Cyclosporin has issues with kidney function as well. And mycophenolate, you have to look at those issues also. These drugs tend to go a little more directly at the immune phenomena that's happening to damage the nerve, the